that Partners in Research, our patient public involvement group for neuroprogressive and dementia network, have chosen, and the topics that have been of interest to Rich Voices, so the patient and public involvement group for Enrich Scotland. So trying to make sure we have a range of topics that we think will be of interest, that particularly focus on kind of research participation, and how to importantly improve choice and options for people. So that being said, in case I forget, we have the next webinar will be on the 28th of March, and that will be the 6-month celebration of the Partners in Research book coming out. So it'll be a chance to chat with the authors about writing a book about their lived experiences, and a bit of a question and answer session. And is that all that? I think that's all the housekeeping, as far as I know. So without further ado, I'm going to hand over to Victoria. Thank you so much for joining us today, and I will mute myself and let you take over the screen.
Lovely. Thanks so much for the welcome. And hopefully you can see some slides coming up on the screen there.
Yeah.
So I'm you from Cardiff, so a little bit further away. We similarly don't have very good weather generally, but the sun is out a little bit today, so we're very fortunate indeed. And I'm based at Cardiff University. I'm a nurse, a researcher, and I lead a programme of work looking at issues around how we conduct research involving people that might have additional challenges when it comes to making a decision about whether to take part in a study and about giving their own consent. And that often raises lots of kind of complicated issues, and my work tries to address some of those issues so that we can make research more inclusive. And the programme is called Consult, and today I'm going to talk about just one specific part of that, which is the idea that we might be able to encourage people to think about, to talk about, perhaps to document somewhere what their views would be about research in the future if they perhaps weren't able to make their own decision at that time. And we've done some work here in Cardiff exploring whether that might be something that's acceptable to people, whether that's feasible. And of course, a lot of this will have a lot of implications for care homes and care home research as well. So I'll talk about that as well. So what I'm going to do is give a little bit of background to the kind of topic, to talk a little bit about what the current arrangements are when we think about research involving people who perhaps are not able to give their own consent to take part, and how that might be different to the way we might think about supporting people to express their preferences about other aspects of their care, their finances, all those things that we think are important. I'll talk about what we mean by advanced research planning and how other countries have done some work in this area already, and then talk about this study that we've led looking at it from a kind of UK perspective. I'm then going to talk about what the implications might be for care homes and care home research, and then talk about what the next steps are for this work. So a bit of background, and you will know a lot of this very well already. But many of the people living in dementia in care homes, and there's probably about 500,000 people in the UK who do, are living with some form of dementia. And of course, for some people, that might affect their ability to make decisions. We know that around 3/4 of people living in care homes might not have capacity to make what we might think of as the big decisions. But also a similar number might not also be able to make a decision about whether they take part in a research study or not, that they lack capacity to consent to that study. And of course, research is really important in terms of how we improve care in care homes and all other settings. And so it's important that we include people in research who are those who are kind of representative, if you like, of the people who actually live in care homes. If we don't include the right groups in research, it means that we don't know whether our findings are really generalisable to those populations. It impacts on the evidence we have for their care. And I often talk about having evidence-biased care. So we have more evidence for some people in society than others. And they also don't have the same opportunities to be included in research as other people. But as I've already mentioned, when it comes to research involving people who are not able to give their own consent to take part, there are particular ethical considerations and kind of legal arrangements that we have to think about. And a lot of this is because we would need to involve someone else to help make a decision about whether that care home resident, for example, takes part in a study or not. And we have lots of different terms that we use. But all of this makes it quite complicated, and this, we think, contributes to residents who are not able to give their own consent often being excluded from research. So researchers will tend to invite people who are able to give their own consent to take part in a study and exclude those who can't. And this same idea has been thought about when we think about older people in general. So this was a report that came out last year that was looking at the future of ageing and how research is playing a really key role in how we can improve the lives for older people going forward. And it talked a lot about how older people have historically been excluded from research for reasons that are directly linked to the experience of ageing, including that people might have more other health conditions as they age, might have difficulties with mobility, perhaps vision and hearing, but also that people living in care homes are often excluded from research, often because we make assumptions about whether they would be interested in taking part or be able to. And that is especially so for people who have impaired capacity, so are not able to give their own consent, who are often excluded altogether. I'll talk a little bit about the legal arrangements, just because I think that will then help think about how this might work when we think about research. So there are a lot of legal arrangements that researchers need to follow when involving people who are not able to give their own consent to take part in research. This varies depending on where you are in the UK and also the type of research. So clinical trials of medicines are covered separately to all the other types of research. But essentially, someone, usually a family member, is involved in helping make a decision about whether they should take part or not. And that decision should be based on what they think the person's own wishes and feelings would be, whether they would want to take part in a study if they were able to say so. And part of those legal arrangements are that they shouldn't be included in a study if it's contrary to any advance statement that they've made. There's no kind of guidance around what people might put into an advance statement about research, whether it replies to research or other situations around their health. And so we have this kind of requirement, but there's absolutely no guidance on actually how this works in practice. And that can be quite a problem. When we think about other arrangements for how we plan ahead for our care and treatment, you'll probably be very familiar with the idea of advanced care planning. So how we encourage people to talk about their kind of goals and preferences about their future care with their family members, the people providing care for them, and that's often written in a care record. But these are kind of goals, preferences, they're not binding in any way, although people can make an advanced statement, so a very specific statement to guide decisions, but again, are not legally binding. There are other types of decisions that are legally binding, and those are advanced decisions to refuse treatment. So you can specify which treatments you would not wish to receive and under which circumstances, and that must be followed for your care. You'll also be very familiar with power of attorney, and there are separate arrangements again for this depending on where you are in the UK. But essentially, when it comes to health and welfare, people can normally say who they would like to be involved in decisions on their behalf. And there's normally a process for that to be formally registered. But that process can be quite complex to do. People might involve a solicitor to help them do that. There's a time and cost involved. And currently, none of these are really considered to extend to decisions about research. So we can make decisions about our future care, but we can't make decisions about what research we might be included in. And that feels like quite a gap. We know that when it comes to families making decisions about research, that actually that can be quite difficult for some family members. They might not be prepared to make decisions about research. They've never thought about it before. It's the first time it's come around. And people don't really talk about what their research preferences are. People might talk about funeral arrangements, perhaps organ donation, those sorts of things, but people don't really talk about what they would like in terms of research. And all of that means that family members can experience a kind of emotional and decisional burden. They find it difficult to make decisions and it weighs heavily on them. And that means that families might be more likely to decline that the person they represent takes part in a study than we know that patients do themselves. They might also say, yes, they would like to take part, or no, they wouldn't, when that's not actually what the person would want. So it might not be in accordance with their own preferences. And all of this means that residents who lack capacity in care homes are largely excluded from some types of research compared to those that are able to give their own consent. And you can see the little quote there in that round circle where a daughter who had acted as a consultee making a decision about research talked about how actually it was quite a difficult decision. So this led us to think, does advanced research planning, so encouraging people to plan ahead of time for thinking about research, actually have a role in all of this? And I've put what we mean by advanced research planning on the screen, but basically it's a kind of process that encourages people to think about, to discuss, perhaps to document their own preferences for taking part in research in the future, if at that point they're not able to communicate their own wishes. It could be documenting that in something that people call an advanced research directive, or it could be naming the person that they would like to make decisions about research on their behalf. And all of this enables people to have the opportunity to think about it at a time when they're able to do so. And that might strengthen the decisions made by other people who later on have to make a decision about research. It might be thinking about a specific research project where people might be able to give their own consent at the outset, but then lose capacity during a study. Or it might be people thinking about their general views, about what their general thoughts are about research. Other countries, as I've mentioned, already have arrangements for advanced research planning. So in Canada, people can already make one of those advanced research directives. In Australia, and it's different in different parts of Australia, but people in some territories can make a medical research power of attorney, and others they can make, again, that same kind of advanced research directive. Germany and Switzerland and some other countries have taken a different route, and they've actually decided that for some types of research, only people who are able to provide consent ahead of time can be included if they no longer have capacity. So in order to include, for example, a care home resident who's not able to give their own consent for that type of study, they would have had to have created an advanced research directive ahead of time, saying that they would like to be included in research. But in these countries, they have introduced this, again, without any guidance to support it. So there aren't any advanced research directives available. So we've kind of set up this rule in law, if you like, without the ability to do anything about it. The UK, quite a number of years ago, there was a report that was specifically thinking about dementia research, and it thought that there should be a recommendation that there should be some kind of ability for people to create this non-binding statement about what their wishes are about research. And that the role of the welfare attorney should be explicitly extended to include decisions over research. But even though this was 15 years ago or so, again, not much more has been done in the meantime. And when we think about why advanced planning for research might be helpful, it might help people to be able to choose who makes a decision on their behalf. It might mean that the decisions about research are more closely based on that person's preferences. It might support greater inclusion of people who would wish to be included in research, and so reduce that kind of experience that family members feel, that kind of burden of making decisions. And it might better align people's preferences about care and the sort of treatment that they would like, and about research, because we often think of those things together, because the option to take part in research is often part of the care and treatment that you receive. But it's not quite so straightforward as you might imagine, because people wonder whether actually people could think ahead of time to imagine what it would be like to be included in research if you had problems with your memory and understanding and not able to give your own consent. People might wonder whether they might be specific enough to be considered actual consent, or whether other people still need to be involved in that decision. And there's also concerns that it's already quite complicated from a legal perspective, and introducing research into power of attorney arrangements, for example, could make that even more complicated. And then also whether what people put into an advanced research directive would need to be interpreted by the person using it to make a decision about research. And we would need to be very careful there. And then lots of practical questions about whether actually people will even do this, given that we know that people don't always write a will, have a power of attorney, engage in advanced care planning already, and research might seem even less kind of relevant to their lives, I guess. Some of the other countries I mentioned have done some research in this area that, again, we can use to think about what it's like for us in the UK. So Canada had a trial where they trialled one of these advanced planning arrangements. They found lots of people were willing to do it, but actually it made little difference to decision making in the end. In America, again, they had a trial and found actually low levels of people completed one of these advanced research directives. And that led them to worry that if, like in Switzerland and Germany, it's a requirement to have one of those, that might stop future research being able to happen. In Australia, they did a survey and again found very high levels of interest in people making an advanced research directive. They've created one and it's now available when people sign up to a dementia research registry. And they're now thinking about actually how they can encourage people to do that kind of implementation into practice. So I say here in the UK, we haven't really looked at that. So the study that I recently led has been exploring whether this is something that might work in the UK, and if so, who. And today we're thinking specifically about kind of care home residents and care homes in general. So we first led a survey. This was across the UK, and you can see we had quite a lot of people taking part, members of the public, which included people living with dementia and other conditions that might affect their memory or understanding, family members, and then lots of professionals, so researchers and healthcare professionals. And they were very supportive of the idea of advanced research planning. So 97% of them thought that they would be interested in doing that. And nearly the same number thought it was important that people have the opportunity to do so. When we asked questions about how binding, how formal a process this might need to be, we had lots of different views, but generally people thought it should be more like advanced care planning and advanced statements. So not legally binding in the way that decision to refuse treatment is. But they also thought lots about the kind of barriers to implementing this in the UK and things that might help. And that was thinking about what kind of support people might need, the kind of when the best timing might be to encourage people to think about this, and the barriers that might be around whether it's accessible to people, for example. Is it just too complicated? Will the forms, will the information be understandable or not? They also talked a lot about how actually it might be best to embed it in all those other advanced planning arrangements that we've been thinking about, and other arrangements as well. So thinking about the opportunities that might already be out there. They wondered whether, even if someone, for example, wrote down their wishes, that someone else might later kind of override them, and whether that might be a concern. And also how people might change their mind over time, and so might need to go back and change what they have said about their preferences about research, and how that might be difficult when we think that people might, at a later stage, now have more problems with their memory and understanding, and that might be difficult for them to do. In the next stage of the project, we did some interviews to try and talk to people in more detail and find out a little more about what they thought. So these again were with the same group of members of the public, carers, researchers, healthcare practitioners, and we did these interviews last year. And again, most people were very supportive of the concept and talked about how they might think about it differently depending on the exact context. So, for example, whether it was a study that might have particular risks involved in it or not, or whether it might be different for some people compared to others. And we found 6 main themes that I'll talk about in the next minute or so. So the first one was thinking about if someone has said what their preferences are about research, actually who uses those preferences and how binding we might think they are, and whether other people should still be involved in the decision or not, kind of interpreting their wishes, if you like. And you can see some quotes there. So one person thought that it shouldn't be legally binding, it should be more a general sense of what the person would want to do. But someone else in the middle there, who themselves was living with a condition that affected their memory and understanding, said, actually, if I've gone to the trouble of writing out what I want and signing that document, those should be their wishes. They should be binding. So you can see that we had different views there. And then when we thought about who else might need to be involved in the decision, so for example, a family member looking at what's in an advanced research directive and using that to make a decision about research, that actually some people thought that was a relief. They quite liked the reassurance that someone else would still be involved in thinking, actually, is this what that they would want to do? But then also the idea that that also creates the opportunity for that person then to say, I've seen your preferences, I know you'd want to take part, but I'm still saying no, that kind of undermining of people's wishes. When we think about the opportunities of embedding it in the kind of already ways that we plan ahead for the future, they came up with lots of different ideas. So you can see donation at the top there. So when people are signing an organ donor card, and that kind of process is a little bit different these days, they might also be able to say what their preferences are about research. Or perhaps that legal planning. So when writing a will, when creating a power of attorney, they could also be asked, and what about your thoughts are about research? When someone takes part in a research study, they could also again be asked, in the future, if you weren't able to communicate your wishes, do you think you would want to take part in other types of research in the future? Or perhaps when we think about advanced care planning that currently focuses on care and treatment, could questions and issues and conversations about research be embedded in that too? And then when we think about life changes, so someone moving into a care home, for example, or being diagnosed with a condition, or have some other kind of change that makes them think a little bit about the future and about what they themselves would like. And then the one at the bottom there, engagement, is that idea that often people are involved in charities that they support, so dementia, Alzheimer's Society, those sorts of organisations, and they could play a role, those organisations, in encouraging people to think about research in the future, as well as the other types of activities they do. One of the other themes that came up was around finding the right timing for this. You can see the quote on the left there that thought that actually some people are kind of busy living their lives. They're not really thinking too much about the future. They perhaps don't really think that they themselves would be at particular risk of getting dementia. So they might not have any interest in thinking about research in the future because it just doesn't feel relevant to them. It's too early in their experiences. But for other people, when it becomes more relevant, they might not then at that point be able to think about their kind of wishes about research and perhaps create a document that contains those wishes. And that sense of, for some people, it might then be too late for their experience. Other people spoke as well about the risks of the kind of unintended consequences. So if people, again, created a document that said that they would or wouldn't want to take part in research without understanding what would be involved, that might be a worry as well, because it might mean that later down the line they don't have the opportunity to take part in, when actually if they had known what was involved, they would have done. And it might also mean that some people don't have access to treatment and care that's currently only available through a research study. So that idea that it needs to be an informed decision. And then we also talked a lot about what sort of format would be best. So this could be a paper document, or it could be online, or it could be both. And people have very strong sense that it could be both. And again, when we think about power of attorney arrangements, that's how it currently works. So you could download print off forms or send away for forms to be sent to you in paper copy, or you could do it online if you wished, and people could choose what suited them best. People also talked about whether actually having a kind of checklist in a way that helped people think what they would and wouldn't want for themselves might be helpful. But other people thought that kind of checklist idea really wouldn't capture what their own wishes and preferences were, that they would quite like to write a few sentences that help them describe what their preferences are in their own words. And other people thought perhaps a mixture of those two might be helpful. What also came up a lot is around the potential risks involved, the need to protect people's interests, but also to address inequality, so make sure that people have equal access to this if we think it is something that people is important to people. And so the quote down at the bottom left there, which talked about the risk if people were kind of forced into a research study just because 20 years ago they'd written down that they would like to take part in research, that might be a real worry, and that in itself could worsen the trust that people already might have in research and in healthcare more generally. And then the quote on the right that talked about how actually it probably is people who perhaps have higher levels of education, who are more used to completing forms, who would complete something like an advanced research directive. And so in itself, it could be a barrier to people being included in research through our attempt to be more inclusive. So again, that kind of unintended consequences, if you like. So just to kind of wrap all that up. So a lot of people were very supportive of advanced research planning. They thought it might help people to think about their preferences, to identify someone they might like to make decisions on their behalf, and help that person be prepared to make decisions in the future. And there are lots of ways that we might think about this becoming a reality, embedding it in some of those opportunities that I already spoke about. And so the next stage is to actually develop some of the kind of guidance and tools that might support people to engage in advanced research planning, thinking about the accessibility components we've already talked about, and informed by thinking about how other countries have experienced advanced research planning and how it might be different in some contexts. So thinking today especially about care homes, and I would really welcome your kind of thoughts about whether this is something that is relevant to care homes so much or not. For care homes themselves, it might be that perhaps people at the point of moving into a care home might be encouraged to talk about their preferences about research, perhaps to document them in some way, or perhaps they might come into a care home already having that in place. And so it's a question of revisiting that perhaps with them and ensuring that those wishes are known to the people in the care home and any researchers visiting. There might also be opportunities when we think about having conversations about advanced care planning in care homes. So those kind of opportunities for all this to come up. But I think further work is needed. So Brittany is a PhD student in Cardiff, and her study is particularly thinking about this from the perspective of care home residents. And her study is called the Engage study. So looking at the kind of ways that we might support residents to make decisions, to communicate their decisions about research at a future point in time. And she's exploring this currently, has just finished some interviews, and I'm sure we'll be very happy to come along and speak in a bit more detail about that with you at some later point. So I'll just kind of recap a little bit on what we've talked about. So advanced planning, we think, is very important for people when we think about their care, when we think about their finances, when we think about organ donation and all those other sorts of things, that we have ways of saying what we would like for ourselves. And if we think that's important, then we probably would also think it's important that research be included in those conversations. And we've got the legal frameworks that talk about how we can have advanced research planning, but there are big gaps in actually how that works in practice or doesn't work at all. And the questions still remain about how all this could work together, particularly when you think about not making it a worse situation. We've got some future research ongoing thinking about how we can develop tools for this, and also thinking about how that might need to be different in different contexts, such as in care homes, where the focus would need to be on communication as well as that kind of recording of people's preferences. And we're doing some more research around this. And there's some contact details for me there as well, so always happy to be contacted to talk about any of these issues. Thank you.
Brilliant. Thank you so much, Victoria. And as a lot of the people who've joined know, I've been buzzing about this talk because I think there is so much applicability to what we try and do in Enrich Scotland in increasing the opportunity for research participation, and what we're trying to do in terms of letting people have more choice and more options. But instead of fangirling over here, I will see if anyone else has any questions for you first. So if anyone has any questions, you can either pop up your hand or put them in the chat. I'll keep an eye on that for you, and we can go from there. So David, on you go.
Yeah, Victoria, very interesting. I must admit, I was busy writing down lots of questions. Unfortunately, you answered most of them throughout the process, and I feel kind of let down by that because I don't really have much to ask you. But one thing I did like the idea of the German model. I quite like that. But one thing I wanted to know is that, does this advanced planning, let's say, document have to be a legal document? And does it have to be separate from a power of attorney or within a power of attorney? I'm just thinking about lawyers. They charge exorbitant fees and would probably, take a fortune off you just for a separate document. And I also think that people will change their mind, as you say, and people will not be interested at a certain point in their life. And one of the things that came into my mind was, would it be helpful if, for instance, that people were asked through their GP what their advanced planning thoughts might be, and to have that put into their NHS record so that it's on file. It's not a legal document, but it's on file, and it does give preferences, and then it can be looked at later when someone is probably diagnosed with a condition that means they will have to go into care, and then it can be revisited. That was just one of my ideas.
Thank you, David. I'm sorry to let you down with the question, but it does sound like you've thought of lots of questions, which is really great. And you mentioned a lot of the kind of challenges that we might think about, because as I mentioned, it's not so straightforward when you actually kind of delve into it a little more than it might seem at the kind of first instance, really. So to think about the legal thing, and this came up quite a lot, and there were thought to be advantages of having it as a legal document. So, they're often registered, for example, in a central place. So there's always a clear record, even if the person loses their own copy, for example. But you're absolutely right. Those kind of questions about the cost involving a solicitor or other kind of legal professional in that. And also it might put people off. Because if you think, OK, now I've created this very legal document, I would have to be really careful about what I've put in that. And so people generally thought it wouldn't be best as a legal document, but would have that kind of advisory role, but stronger than it just being some advice. It should be something that people should follow, unless there were particular circumstances or particular changes that actually the person using those wishes thought, if the person had known that would reflect their wishes. So that very much came up in the interviews that we did. The GP thing was really interesting as well. So a lot of people spoke about how that might be really helpful. A lot of people mentioned that even getting to see a GP these days can be quite difficult. And of course, it might not be someone who's very familiar with you. Ideally, it would be, but often that's more of a challenge. Other people thought maybe something like a memory clinic, so where you're already attending somewhere, and they could include that in conversations. And again, the idea being that people perhaps wait a long time to get an appointment with a memory clinic, and even when they do, it might just be a one-off appointment for an assessment and then not followed up again. So there are kind of areas where it would be ideal, but possibly some practical issues to consider. And that linking with the health record again seems ideal. That it could sit with, you know, your other kind of important information about you from a medical perspective. And then other people wondered, actually, would they be able to have access to it themselves to update it if it's on your health records or not? And I think in different parts of the UK, sometimes people can access things on an app and other sorts of things. It's often a bit different in Wales, but where you could, that might be an opportunity. But again, not everyone would have access to that. And then other people thought, OK, if you think about from a care home perspective, where your health records, your NHS records, the people within the care home might not have access to because they're in another healthcare setting, or your GP has access, but your hospital doesn't, and those sorts of things. So you're absolutely right. There's a lot of those things to think about. And that being able to update preferences was something that came out as really important, that people might change their mind over time and wouldn't want to be held to what they had previously said. Some other people thought that actually when it comes to research, people probably don't change their mind a whole load, unlike perhaps other decisions, but people might have different views. And of course, research and treatments are changing all the time, aren't they? So there are treatments becoming available now that we never thought were possible. And so we might not have thought about from a research perspective a while back because they didn't exist. So yeah, really interesting points to pick up there.
The other thing I was thinking of was that people may agree to medical trials at an early stage and then go into care. And once they're in care, they're given medications for their condition, which could have an effect on any trials that may come later and they had already agreed to. And as you said, the staff within the care home wouldn't have access to the medical records. So that could be a problem area as well.
Yeah, absolutely. And one of the reasons for thinking about this now is, you know, treatments for conditions like dementia, for example, are in the very earliest stages of being tested, aren't they? And some of them might go on to think about how we can actually improve the lives and well-being and symptoms of people with more advanced dementia. So thinking about this now might help us in the future when we do have other sorts of treatments available that we don't currently. But yeah, it's a really interesting topic.
Yeah, thanks.
Thank you. Just before I come to Winnie, there's because of what Maria's noted in the chat. Maria, did you want to say a little bit about another possible Scottish option?
Yeah, I loved the presentation. It's such a worthwhile topic area, and just thought it sounds like something that would go really well with the confident conversations that Dr. Emma Law has developed within the NDN, because I think part of like one of my concerns would be the people who are having conversations around research involvement need to know what they're talking about, really, and to have it opened up to health and social care professionals and GPs and things like that who are doing this anticipated care planning with a person. If that was to be embedded in that, then yeah, they just really need to know what they're talking about themselves. And I think a lot of understanding, when people think about research, think about clinical trials and things rather than all the other options available. So,
yeah, thank you, Maria. That's really helpful. And you're right, a lot of advanced care planning and other types of decisions and conversations happen all the time. And we know that people aren't necessarily very confident in having those conversations, perhaps, you know, require training and support to do that. And so we don't think that advanced discussions about research would be any kind of quicker than that. You know, there's a lot to learn, I think, about the sorts of work that goes on, and as you've mentioned, the sorts of initiatives and tools that are around there, rather than reinventing anything. But it will require, I think, people to have a good understanding about what research is, as well as to then have a discussion about future research preferences. Yeah.
Thank you. And then Winnie, coming to you.
It was something that occurred to me about research. When you talk about research, you're thinking about things, from my point of view, I'm thinking of like clinical trials, things that I can do online, but I've got to answer questions. But I know that my husband had dementia, and when he had to go for treatment for, he had squamous cell cancer and he had to have it cut out. He turned and said to me, "Why are they torturing me?" That was the only way he could explain it. And I was thinking how some of these clinical trials can be invasive. And I think that would be, for me, I think as I got older, that would be a thing I would think, did I really want invasive procedures done on my body? Does that make sense?
Yeah, it really does, Winnie. Thank you. Yeah, really makes, and it brings a lot of these issues to life. That's the thing. You know, these are not theoretical, are they? These are, you know, people's experiences often at a very difficult time. And I think it's that idea that it might be very difficult to know for any particular trial, for any particular health condition, exactly what is involved, because, you know, how could you imagine all the different types of clinical trials for all the different conditions you may develop in the future, for all the different treatments and what might be involved? And I think it's more about thinking about what people's kind of core values, preferences and wishes are, that then might help inform a decision about research. So if, for example, someone thought actually quality of life is much more important than the number of years of life I have, and are able to kind of express that in a way that might help someone in the future think, okay, here's a clinical trial coming up, it's all about maximizing survival, for example, but there will be a downside in terms of quality of life in the short term. The person I'm representing, I knew actually really valued quality of life, and so maybe they wouldn't want to take part in that trial because there are those kind of additional burdens involved that will impact on quality of life in the shorter term. So you're absolutely right. It's all about thinking about what the kind of different features are for a different study, and that could be very different for a clinical trial, couldn't it, compared to I don't know, taking part in a music class, for example, or you mentioned about taking part in an online survey or something. All those are very different, but knowing what really matters to people can perhaps help people make decisions about whether that particular study is what they would have wanted to take part in or not. But yeah, it's really useful to hear your thoughts, Winnie. Thank you.
Thank you, Winnie, and I'll move on to Alison.
Yeah, I was kind of thinking as you were talking about the various, you know, principles are good, research is good. There's many variables, isn't there, with people with dementia, because at different stages. So someone, for example, who might be in a care home would probably be in an advanced stage where they weren't able to be cared for in their own house. You know, it was maybe a bit more too much, you know, for a domestic setting. In which instance, you know, you think about then participation, you know, the ability to participate and how that could be managed. And then, yeah, there is the ethical consideration around, because if there's a proxy in place, whether it be power of attorney or guardianship, does it fit the principles? You know, is it in the adult's best interests? Is this something that they wanted to take part in? How do we measure that? If someone's the guardian, particularly the local authority, how easy is it going to be to get any kind of consent from them? You know, because there's so much we can learn from people with dementia, even observation, I think is a good way, if not the communication skills are maybe a bit limited. So that's kind of things I've been thinking about if you've been speaking.
Yeah, thank you, Alison. And it's that idea that, you know, what came across in the interviews was the idea that this isn't perfect, but it perhaps is better than the current situation where we find ways to think about what someone would have wanted about research.
Yep.
Without asking them. and so, you know, there are currently already mechanisms in place for, as you say, thinking about whether it's in someone's best interest or not. And so actually kind of taking it back a few steps, and for people that might be interested, having a conversation about actually what is about research. It's probably about prompting and initiating those conversations when we can do so. that's probably really key, and that helps prepare those people that are involved in those decisions further down the line. And you're absolutely right that when it comes to local authority, social workers, other people that have a professional relationship with that person who might not have known them at a previous stage, there's also that kind of question about whether, for example, having something in a written directive might help those people to make a decision in the absence of any other kind of prior relationship with them, or whether it's really only best used for families that perhaps were part of that conversation that helped them to write the document, for example, and so know something more about the kind of wider context as well as whatever is in that document. And people talked as well about emergency research. So if you have a heart attack in the street, for example, and are rushed into hospital, nobody knows you. They need to do research into those conditions as much as anything else. And currently you're included in a study, again, with nobody having access to any information about what you think about research. And that probably goes back to David's thoughts then about whether something in your health records that indicates your general thoughts about research may or may not be helpful. Yeah.
Thank you very much. Susie.
Yeah, brilliant, Victoria. It's so interesting, isn't it? So many complicated things to think about. When you were talking about that, it was just making me think a little bit about the change in legislation around organ donation, moving from opt-in to opt-out. And I suppose there's something around that. There's a presumption that you need to opt into research rather than the presumption you would want to take part and you should opt out. And it was what Whitney was saying. It's so hard because research covers everything from being injected with really toxic drugs to having somebody watch what you do to using your data when you take you're part of a social care or a healthcare system. And it would be very hard to advance plan every single eventuality when people when you write a birth plan, you don't even know what's going to happen when you get to the end of the story, do you? So yeah, how do you negotiate? So opt-in versus opt-out, and then how do you negotiate the wide range of different options that research encompasses?
Yeah, thank you. And yeah, two really good points. And again, that opt-in, opt-out thing came up a little bit. And, we see that all the time, don't we, about the idea being that opting into things requires people to know they have a choice about whether to opt in or not and be able to communicate that choice, to be able to kind of exercise that choice, if you like. And research, I think already generally there is a little bit of that, isn't it? When we think about the use of routine data held by you, so things held in your records that don't perhaps identify you, there are already certain arrangements where you can choose to opt out of having that used. Otherwise it's used for those kind of certain studies that link those different types of data. But that for some people might not ever be in a position to be able to opt out. So a lot of that came up from that kind of observational health record data perspective, but also from an emergency research perspective as well, where you don't have an opportunity because who knows who might be at risk of a sudden cardiac arrest in the street, for example, to know that you could opt out of being included in a cardiac arrest trial. So you're right, there's a lot around that kind of issue too. And your second point, and the birth plan idea is something that comes up a little bit, doesn't it? That people often spend time thinking about, actually, in terms of birth, I would like, scented candles, this type of music to avoid those kind of painful, pain relief things that I prefer not to have. But actually, in the moment, other things happen, and it might not be something that ahead of time you thought would be the way that you would go. But actually, even talking about your birth plan with people and saying, to be honest, if there is a way of avoiding an epidural, some other kind of intervention, I would quite like the least intervention possible. And so there's something about having that conversation and saying what your kind of broad values and preferences are that might be helpful, even if you're right that in the moment it doesn't have any applicability because everything kind of happens outside your choice. So it's very much that how specific it needs to be versus how general it needs to be, and which of those are more use, or quite possibly a combination of those. So that Australia version I mentioned has general statements about your general thoughts about research, and then you're able to put more specific preferences behind that. So things about perhaps risk, things about invasiveness, types of research. So you do have some option to kind of specify the level of preferences you have, which may be one way, I guess, to go.
Right, we've got time for one more question, David, so I'll let you come in there and then we'll wrap up. You're on mute there, David.
Just thinking about the opt-in, opt-out situation, wouldn't it be and make things easier if people were allowed at the advanced planning stage to opt out of specific research things like organ donations, etc., and leave the rest to their attorney, provided they have one, to make a decision on their behalf later? That would make it, that to me would simplify things.
Yeah, and you're absolutely right, David. To some degree, it would. And then we think about people that don't ever have that ability to do that. So perhaps a lot of the work I do is around people with a learning disability, who may have very strong views about what the choices are, what they would and wouldn't like to be included in. But perhaps to nominate a power of attorney to create an advance directive might be something they'd be wary of doing, probably needs support to do. So there are perhaps for some people that might not enable them to have the choice that we think is important, and that's that sort of accessibility idea. And there might be other groups as well. So we think a lot about literacy and those kind of aspects as well. So there are lots of these things that are very nuanced, aren't there, that might make something accessible for more people, but perhaps there might be other populations we might leave behind. And that is very much the kind of underpinning thoughts, I guess, around how we can try and make whatever these kind of processes are accessible to the broadest number of people without disadvantaging people further who already are kind of disadvantaged. But yeah, really, really useful to hear your thoughts. Thank you.
Thank you so much, Victoria, and thank you again for coming and sharing your work. I think it says a lot when one question actually opens up the door to so many more questions for us all to think about. But there's a lot that I think applies to the work we do, and a lot of things that I think people will go away and digest and think more about. There's also, I think, going to be a lot of people catching up online with this presentation, as I know there was lots of people who wanted to be here who are unable to. But thank you again for taking the time to come and speak to us. We really appreciate it. And it's really great for us to be able to hear what research is going on and see the different options that people have. So thank you very much.
Thank you very much for the invitation, and thank you everyone for your questions and comments. It's really helpful and really interesting. Thank you.
Brilliant. And just a reminder for